Today we're going to be starting a course on psychopathology or abnormal behavior or DSM-5, whatever you want to call this. And we're going to take on a major challenge that most people don't do in this particular area. As an example, many times you'll get a seminar just on DSM-5, and what are you going to get? How is it different from DSM-4? Well, some of you know what DSM-4 is, and let's define what we're talking about: the Diagnostic and Statistical Manual of Mental Disorders. It's built and put together by the American Psychiatric Association. Psychiatric means they have to be a doctor. They're the ones that give the medicine and those kind of things. And it's their organization that spent 12 years putting this new manual together, and it just came out this May. But we're going to go further in this class than just helping you understand this manual. And this is the DSM-5, and this is what it looks like, and that's how thick it is. And so there's a lot of information that we're going to try and digest here. But we're also going to do another thing. We're going to talk about treatment and the etiology of why some of these things occur, and that's going to be based on the Clinical Guide to the Diagnosis and Treatment of Mental Disorders by Fist and Tasman. And then we're going to take that and take the Bible, and we're going to look at the Bible and try to understand all this stuff and put all this stuff together so you have sort of an integrated overview. And this is an overview, okay? Now, what are our goals? Our first goal here is that you understand about mental disorders. Now, how do mental disorders fit with other things? Well, let's just say over here we have fairly healthy people that we would call normal, okay? They have some codependent issues. They might have some characteristics of some of these problems that we're going to be looking at, but they don't have enough characteristics to say they really have the problem. Then we have what we call codependency. So this is functional. Codependency is sort of dysfunctional, from a little bit dysfunctional to a lot dysfunctional. And then below that we have mental disorders. This is non-functional. This is where their life is really greatly impacted. In fact, if their life isn't greatly impacted, it's not going to be considered a mental disorder. And we're going to find out as we get deeper into this, there are certain things that you might even have the problem, but if it doesn't greatly affect you, it's not going to be considered a mental disorder. So why do we have this manual, and why did they bring a new one out? Because everyone needs to be on the same page and basically figure out what is going on so we can communicate with professionals in the field. And in this class we have some professionals here, and that you can be learning and using this for your continuing education credit. You can be using this to learn to diagnose, because you can get to the clinical level as a licensed professional and diagnose. But for most of you, this is going to be about assessment. And so when somebody comes in and says, well, I've been diagnosed with bipolar 1. Well, you know what bipolar 1 means, you know the different levels, or if they send you information from their records and it's all listed here, you know what that all means. And so the idea is to keep everybody on track, and then to take all the research about all of this stuff and to figure it out and to do the better job of understanding everything. And there are problems, because what's the main thing we're trying to do here? Well, remember, the people that put this together are doctors, right? And we're talking about diseases, right? So what's the problem? We're trying to take brain functions and what's going on and how somebody's functioning in their brain and make it like, I got a broken bone, or my thyroid isn't functioning right. And we're trying to put it all in the same system so that this can all be integrated, and that's a very difficult thing to do. And what they learned, one of the reasons they brought this manual out, is they're learning more and more that instead of these being discrete problems, like we got this problem, we got this problem, and we have this problem, they're a continuum of problems. And so they made some major changes because of all of that. So we want to understand these diagnoses and what they communicate. We want to realize the limitations. There might be certain things here that you realize because they're really physical, or because that's what causes them, you need a doctor involved in the treatment. Or there might be some things you need to refer to somebody else that knows more about this than you know about it. We want to use correct nomenclature when you're talking about things, when you're writing your letters and so on. Or what are they going to basically think? This person hasn't got a clue what they're talking about. You cannot independently practice in the state of Kansas to do diagnosis unless you are licensed at the clinical level. As an example, I am a licensed clinical marriage and family therapist. That means I am licensed to diagnose here in Kansas. And I can do that. So anyone that comes in, I can take DSM-5 and I can make a diagnosis to determine what the problem is. Another thing we want to do here, though, is we want to relate this to treatment, and we want to relate this to the spiritual. What's one of the problems that we have in this whole area, especially in the area of mental disorders? Well, there are a lot of Christians going around, and they basically say, well, that's just all demonic. So they just try and cast the demons out of everything. And then we have a lot of doctors going around, and they say, well, that's just all physical. So all they want to do is give a medicine. And then we have other people going around that, well, that's your choice, that's sin. And then we have other people going around that say, well, it's because of the trauma that happened in your life. Well, the confusion here is, the answer is yes. It can be all of those, and each one of these is going to be very different. And we're going to look at that, and we're going to try and do a special way of looking at each one, because we have to determine how much of this is spiritual, how much of this is a physical malfunction, how much of this is their past experiences, and how much of this is choice, in order to treat them correctly and to have any clue of what we're doing. And that's why this type of counseling we're talking about here is the most difficult type that there is. Because you have to sort this all out and get the right treatment and the right people helping people to the degree that's possible. One other thing we need to talk about, though, we're talking about DSM-5 here. We need to talk about the ICD, or the International Classification of Disease, because that's the way all this stuff is coded. And you're going to find out in DSM-5, after every one of these things, they're going to give you an ICD-9 code, followed by an ICD-10 code, and 2 years from now, they're going to give us an ICD-11 code. And these codes don't even look the same. ICD-10 codes all start with letters. No ICD-9 codes start with letters. And so it gets very interesting as we get into all of this, but we're going to talk about that. But the first question we have to ask is, what is abnormal? If we're talking about abnormal psychology or psychopathology, what is abnormal? Then we have to ask, what is normal? How do we determine what is normal? What's going on here? Well, there are a lot of factors, and there's no universal answer. So one of them is culture. Does it fit within the culture? Now, your culture is different. One of the problems we ran into in our domestic violence program here is when we had Muslims come in. Because to them, domestic violence is acceptable within the family. That's normal. How about in Japan and in Asia? If things don't go right, you commit suicide. We were just in India. You know what normal in India is many times? Since you can't really get out of domestic violence situation, and since you believe in reincarnation, you just hang yourself from your ceiling fan. That's how a lot of orphans are happen in India, is because the moms couldn't get out of a domestic violence situation. It was easier to just check out and start over. And so there are a lot of orphans. So it depends on the country. The wannabe tribe. In that particular tribe, the men wear makeup and costumes to attract the women. See, if you saw somebody and you didn't realize they were from that tribe, and you didn't realize the cultural differences, what are you going to do? I think they got a problem. But no, they're doing what is normal in that particular tribe. So we have to watch out that it's not cultural differences and we're now diagnosing some mental disorder because this person has a cultural difference. Societies have, in value, differences. How about intelligence? Some societies, aggressiveness, extreme unselfishness. Think back in history. The Spartans, what did their moms tell them? Come back with your shield or on it. Your job is to go out there and die for the country. How about kamikazes during the Second World War? That was heroic from a Japanese standpoint. High achievement is one of the real struggles. Here in America, in India where we're just at, it's huge. Here in America, I've had 2 clients that were suicidal because they were getting bad grades in school. It's not unusual in India. How are the norms set that we're talking about? Well, it might be history, values, institutions, habits, skills, technology, arts, politics. And unfortunately, because of all that, politics is involved in DSM-5. Now, they've solved some of the issues that they've been struggling with. Most of you know that homosexuality is not in DSM-5 because it was voted out. Another issue that we're going to see that's in DSM-5 now has to do with premenstrual syndrome. Why do you think that was a problem? What did the women say when they wanted to put premenstrual syndrome into DSM-5? That means all women have a mental disorder. So they didn't want it to be that way. Now they got around that, and we'll get into that later, okay? So what's the criteria that we're looking at here? To be abnormal, it has to be these 4 things. You need to get these down. It has to be deviant. It has to be distressful. It has to be dysfunctional or non-functional. It has to mess up the functioning of the person. Or it has to be dangerous. Those are the basic criteria. But now here's the question. So, is it deviant, distressful, dysfunctional, and dangerous enough to be considered a mental disorder? See the problem that we have of trying to define all of this. And so that's why they do so much research and they try to get a consensus of all the different people. And because of that, there are a lot of things that are in the back of DSM-5 that are areas for further study. A lot of people are disappointed because some things that are not in DSM-5 include sexual addiction, include problems with pornography. They never made it in there. Another one they wanted to get in there that they were not able to get in there is internet gaming, playing games on the internet and being addicted to that. So to see the idea. Now, what's another criteria here? The diagnosis of a mental disorder should have clinical utility. That means it defines one thing from another and it's useful in the way it's being discussed, okay? It should help the clinician to determine the prognosis, that is, what's the possibility of this being helped, the treatment plans, and potential treatment outcomes for their patients. In other words, this isn't just a manual to make us all happy and give us some terms. The terms need to make a difference or you shouldn't have the terms, right? Because of that, you're going to find out they took a whole bunch of terms, especially in the area of schizophrenia. There used to be a whole number of different types of schizophrenia. There aren't anymore. And so we're going to look at all that stuff as we look at it. So what's their definition of a mental disorder? And this is directly out of the book. A mental disorder is a syndrome characterized by clinically significant disturbance in an individual's cognition, emotional regulation, or behavior that reflects a dysfunction in the psychological, biological, and developmental process underlying mental functioning. I know that's a lot, and we'll give you a chance to copy that down later at some time, but let me read you the rest of it, because it's not done yet. Okay? Mental disorders are usually associated with significant distress or disability in social, occupational, or important activities. An expectable or culturally approved response to a common stressor or loss, such as the death of a loved one, is not a mental disorder. Socially deviant behavior, politically, religious, or sexually deviant behavior that conflicts primarily between the individual and society are not mental disorders unless the deviance or conflict results in a dysfunction in the individual as described above. Now that's a lot, okay? So let's go look at it for a second, and let's see what it really said. It said, first, it's a syndrome, meaning it's a particular pattern of things, okay? And it's clinically significant. It means when a doctor looks at this, they say, yeah, this is a real problem. It's a disturbance in cognition, that's thinking, emotional regulation, that's how you take care of your emotions, or behavior, and it's a dysfunction, psychologically, biologically, or developmentally. So those are sort of the criteria. That gives us the sort of overall picture of what we're going to be looking at here. The other thing that this manual does is it gives you the prevalence. That means how often you see it in society. And we're not going to go into a lot of that. Each one of these, it gives you all the statistics. For 30 to 38% of adults and 17% of children need clinical treatment each year. So you see the range there. 11.2% have panic attacks every year. 8.5 to 16% have addictions to drugs or alcohol. 7% have profound depression. Alzheimer's disease, below age 70, is about 5 to 10%. After, it's 25% or higher, and increases the older a person gets. Borderline personality disorder, that's only 1.6 to 5.9%. But if that means up to 6% of everybody in society has borderline personality disorder, we've got some major problems, right? Schizophrenia is 0.3 to 0.7%, and the rate's the same with all societies. Okay, so that's sort of the overall picture. Now the question is, let's go look at the history for a little bit, and let's just see how this whole area has had problems in the past. If we go back far enough in history, what was the primary way of dealing with if people had problems with their brains? Drill a hole in their brain to let the spirits out. Okay? Hippocrates believed that there were 4 humors in the body, and that so if somebody had a problem, you bled them to balance those humors. In fact, that's one of the things that led to George Washington's death. He had strep throat, and they bled him again and again. He got weaker and weaker until he died. But that was usual at that particular time. Middle Ages, they saw it the work of the devil, and so they would actually harshly treat mentally ill people. The Renaissance, they finally had asylums where they would just lock them all up. 19th century came more humane treatment, and they realized that there were some particular things, like syphilis was figured out. It wasn't really a mental illness, it was a physical illness, and so on and so forth. Hypnosis was used in the 1800s for people with what they call a hysterical disorder. But since 1950, we have psychotropic drugs, basically that affect the neurotransmitter dopamine, which help people control these kind of problems in their lives. One of the breakouts that I just was at in the American Association of Christian Counselors International Conference was Dr. Meyer, who is a top name in all of this, of all the new drugs and things that are available that will help these people. But see, that helps us understand how much of this is physical or how much of this is spiritual and so on and so forth. Treatment models. We got all sorts of treatment models. What's the problem? We needed to use the right treatment for the right problem. And that gets very confusing here. I'll just list them for you. Some of you know we have biological or medical model, basically feeling almost everything is a chemical imbalance or something like that. So those are mostly treated always with drugs. We have psychodynamic, that causes underlying conflicts. Behavioral, based on classical conditioning. Cognitive, you have lies of the way you're thinking and we straighten out your thinking. We have a humanistic, existential. Self-awareness, self-actualization. If we just give you positive regard, you'll be okay. Social cultural, it's caused by outside stressors. The diastasis stress model. You have DNA issues, and then if you have stress that goes along with that, then you get the problem. All successful therapies, though, have what? They have the attention to the individual. They have a credible rationale for the problem. They have some experience of mastery or success working with the problem. They raise hope or expectation. And they have an alliance with the counselor. So a lot of things can help, but not everything's going to help in the same way. And some things won't help at all if you're dealing with the wrong issue because you don't understand what's going on here. As an example, if a person has a fear or a phobia, then you're going to want to use behavioral training because systematic desensitization, as an example, will be able to deal with 90% of all those people in a very short period of time. They'll be able to get over their phobia. Schizophrenia. It's very highly genetic, and therefore different medicine to try and control that is going to be one of the main things. Cognitive behavior is very good for panic attacks, sexual dysfunctions, other things like that. Cognitive plus drugs for depression. But we'll get into all that stuff, okay? I'm just giving you ideas as we go along here. Let's talk about assessment a little bit, because that's what this course is basically about, is assessment. So how do we normally assess people? It would be very nice if we had some tests that we could just give you, and we take a blood test and we could tell you, yes, you're anxious. Well, we're not at that level, okay? Now, we are starting to see brain scans to determine what kind of ADHD a person has and some other things like that. So it's going in that direction. But right now, in most of these disorders, we don't have anything that will say, this is what you have and you have it for sure. Because that'd be very nice if we could do those things, wouldn't it? But we really don't have that. So we have a clinical interview. You ask questions, and that's the way DSM-5 is set up. Is you ask questions, and if you have so many out of these questions are positive, then you say, yes, they have the characteristics or the symptoms, and because they have the symptoms, they have the disorder. Well, what happens when the symptoms change? The disorder changes. And so it's very difficult that way. Now, there are quite a few tests that they have, and psychologists use a lot of these tests, like in some of these things you can test for, like intelligence. So there are intelligence tests, there are some physical tests you can take that will help in these different areas. Clinical observation. But the main area of diagnosis is using DSM-5 to determine what a person actually has and what's going on. But let's look at that for a little bit. Scientific, social, political, and personal needs are all involved in this, and that's because there's the political part of this. It's sort of whoever has the power gets to determine what these things are. Reliability, about less than 70% agreement, but they're trying to make this better every time they publish it. That's what they're trying to do. So that means if you took two qualified people and they worked with the same person, in 30% of the time they would come up with different diagnosis. Not too good, right? Poor validity, but they're trying to improve that too. That means that if we can test it by DSM-5, we can determine what this really is, and we all agree of what it really is. They're trying to also work and make this a more international document now and more culturally sensitive. Before, this was primarily used in the United States, but they're trying to make it worldwide and work in that particular direction. Reassessment studies, though, haven't really come out very good. Meaning what they do is they have people maybe in a mental hospital, and so they then take all the records and give them to another team, and they say, what's your diagnosis? As an example, in one hospital, they had 89 people diagnosed with schizophrenia, and the new team that diagnosed them only had 16. And in mood disorders, they had 15 that supposedly had mood disorders, and then they had 50. And so there's a lot of confusion here. One of the classical studies, and we're not going to get into this a lot, is that they took the records of the people running the mental hospital, and they made them records, and then they took the records of the patients in the mental hospital, and they mixed them all up. And guess what? The team of experts couldn't determine which were the patients and which were the clinicians. So there's a lot of interesting things that have been done over the years over this, but the point is what? We're trying to do the best that we can to make all these things work and to make all this stuff happen. How does the Bible look at this? Well, in the Bible, and if you take our course in transformation, you're going to learn about the tribes in Canaan. And we interpret all those tribes as the DSM-5 of the Bible, because the Bible breaks it out in a different way than maybe this is broken out in the manual that we're looking at here today. One of the tribes is the Amorites, and that is prominence or significance problems. The Hittites, those are fear problems. You don't have to get this all down, but it just give you an idea how the Bible has its own way of looking at the different problems. The Perizzites, those are boundary problems. The Canaanites, that's low self-worth. It means lowland. Notice something, it's the land of Canaan. All the rest of them are the children of Canaan, which says all the problems are related some way to low self-worth and how you see yourself and to your identity. The Hivites, life-giving desires or lust of the flesh. Those are the addictions. The Jebusites, it means to tread down. Those are the impulse control problems or abuse type of problems. And the Gergesites, which means to be stuck in the mud or to turn back, are the emotional problems. So we're going to try and translate some of that in here and see what's going on. How many of you here know anything about DSM-4? Raise your hands. A few people that know something about DSM-4. For the rest of you, I'm just going to tell you the changes between DSM-4 and DSM-5. So you have sort of a big picture overview. In the lessons after this, we're going to be going into each particular area and telling you exactly what they're like and getting a lot in more detail here. This is an overview here today. In DSM-4, there was the 5-axis system. That means that they broke everything down. First, if you had an acute mental problem, if you had a person, that was axis 1, personality problem was axis 2, then we had a medical problem, then if you have a social problem, and then there was the GAF, with the general functioning. That's all gone. It doesn't exist anymore. Now everything is only on one level, and you have specifiers. As an example, in the area of drugs and alcohol. We were always trying to determine with our tests whether a person was dependent or whether they were an abuser. Now we don't have the dependence and the abuse. Now we have mild, moderate, and severe. And that's the direction they went. Remember what I said? They're looking and saying these things aren't like you have this or you have this. They're more of a continuum. So now that's all set up as a continuum. So that's a major change that they had there. There are more, the areas that aren't diagnosable but are areas like you have problems in your family, they're called V codes. And we still have those, but they're going to be changed to Z codes when we get to ICD-10. Another thing about DSM-5 is it's now totally reorganized. In the past, it had these different categories. But now the whole book is organized based on starting when you're problems when you're a child, all the way problems when you're an elderly person. And so they reorganized the whole book in those particular categories as we went through those in the developmental order. As I mentioned, we do not have the sexual or internet addictions in the main body. Here's an interesting thing that I was surprised to sort of see. Under dissociative identity disorder, how many know what that is? Okay, that is what they used to call multiple personalities. Under there, they have another type of DID, which is basically demonic possession. Because other nations and so on, they saw more of that, and so they were able to get that in there. So we'll be talking more about that when we get into that particular area. They took what was called mental retardation, is now called intellectual disability. And they combined the cognitive and the functioning together. A whole bunch of these areas were all brought together. We used to have these separate things like this, and they're now all one category. Autism spectrum disorder is a big one because we had all those different types of autism. Don't have that anymore. You might have specifiers, but you don't have those things anymore. Communication disorders, they're all combined. ADHD is now recognized as a neurodevelopmental disorder. And they only have the inattentive and the hyperactivity, impulsivity types. Instead, they used to have 3, now we only have 2 there. Motor disorders are all combined. Schizophrenia, we don't have all the types. There used to be a paranoid type, a catatonic type, and all of those don't have that anymore. They're all called schizophrenia spectrum disorders. To have those, you have to have delusions, hallucinations, or disorganized speech. Catatonia is now a specifier. What does that mean? It means a lot of those things that you had, like paranoia, you can now use specifiers for different areas. Same thing with panic attacks. In panic attacks, there's a panic disorder, but you can now use that as a specifier. So you can have anxiety with panic attacks. Delusional disorder no longer is required to be bizarre. Bipolar and depression are now totally 2 different things. Bipolar in the past was this idea somebody has a high and then they get depressed. Well, they found out that that is really related a lot genetically and has a very strong physical component where depression itself does not. So those are 2 totally different categories now. They added one called disruptive mood dysregulation disorder. And that's only for children, because a lot of children are being diagnosed with bipolar and giving bipolar medicine. So now they have a whole new category to look at just children in that area. They used to exclude bereavement from depression. But what they found out is that the bereavement sometimes caused long-term depression. So those are not, you can now have bereavement caused by depression. OCD, PTSD, acute stress disorder were all moved to a separate category called trauma and stress-related disorders. And you now have specifiers of depersonalization and derealization. You even have a new criteria for PTSD, that's post-traumatic stress disorder, for some of you who don't know that, for kids that are 6 years old and younger. And so there's different criteria for a child than it is for an adult. There's now separate anxiety and selective mutism are now categories of anxiety disorders. OCD and related disorders now include a lot of other things. So there's different categories. They've taken this whole thing and really sort of resorted it. Hair pulling disorder body dysmorphic disorder. Hoarding disorder is new. You're now diagnosed with a hoarding disorder. A skin picking disorder. Substance and medical induced OCD. So we never had that before. Basically, OCD can be caused through certain medicines that you're taking. Eating disorders now do not include avoidant restrictive food intake disorder, which is differentiated from anorexia nervosa, but they now have binge eating disorder. So if you're binge eating for a certain period of time, and you're not purging like you would in bulimia, that's now a new disorder. Adjustment disorders. This is what we all used to use for everything. Okay, the idea is somebody has a problem and they're having a problem adjusting to it. So that was the catch-all. When you couldn't get another diagnosis, people used this all the time. But they've redefined that. They've determined that adjustment disorders have specific things about them. They're not just something else that we diagnose. So that's a change there. Reaction and attachment disorder. This is when kids don't attach. Well, they now have two categories of that. There's also that, and there's disinhibited social engagement disorder. They found out there were some kids that were not, it wasn't a problem of attaching, they were just not socially engaged. So we now have those as two categories. As I mentioned, dissociative disorders now include depersonalization, derealization, but they have pathological possession. That's what we would call demon possession under the dissociative identity disorders. Satiform disorders are now referred as somatic symptom disorders. These are disorders that are not physical. They're based that your brain is causing them, but they look like physical things. But they've changed that a lot because you can't really diagnose that unless you can prove that there is a problem. In other words, you can't possibly be physical. What used to happen, we get a lot of referrals this way, is the doctor has somebody that comes in and they have a problem. And they can't find out what's wrong with them. So they just assume it might be psychologically caused and they send them to a counselor. Now they've made that you have to physically figure that out. As an example, I was counseling somebody and they were having seizures. And when they would put an EKG on them, there was nothing happening. That would be one we could put under this new category. And finally, medically explained symptoms are limited to conversion disorders that are physically contradictory. What's it saying? It just can't be, we don't know what it is. It has to be something that we can tell that's physically something wrong with that. Let's go a little bit deeper here from a Christian point of view. What does the Bible say about these different disorders? And the very God of peace sanctify you wholly. And I pray, God, that your whole spirit, soul, and body be preserved blameless unto the coming of our Lord Jesus Christ. According to the Bible, what are our categories? Spirit, soul, and body. So maybe we need to use those same categories. So we're going to break things down in this class into SPEC. S-P-E-C. Spiritual. And what you're going to find out here, what's very interesting is, Jesus was doing this 2,000 years ago. Because you're going to find out, I'm going to give some Bible verses here to show you that Jesus didn't always cast out demons. Sometimes he healed a person with the same problem. So he was differentiating what the real problem was in the way he did the treatment. And one of the multitude answered and said, Master, I have brought unto thee my son, which had a dumb spirit. Verse 25, and Jesus saw that the people came running to him. He rebuked the foul spirit and said unto him, Thou deaf and dumb spirit, I charge thee, come out of him. So he cast out the spirit in that case. So that's what we would call spiritual, right? Okay? Then physical. Matthew 15:30. And a great multitude came unto him, having with them those that were lame, blind, dumb, maimed, and many others, and they cast them down at Jesus' feet, and he healed them. So he knew when to heal and he knew when to deal with the spiritual. John 4:16, Jesus said unto her, Go, call thy husband, and come thither. He was dealing here with trauma, dealing with the problems this lady, the experiences this lady had in the past. And finally, choices. Luke 7:37, and behold, a woman came to the city, which was a sinner. When she knew that Jesus sat at meat in the Pharisee's house, brought an alabaster box of ointment. And he said unto her, Thy sins be forgiven. If you don't have choice, do you have sin? No, you don't. So do you see, we're going to have to go through each one of these and break them down and say, how much of this is spiritual? How much of this is physical? How much of this is the trauma experiences the person had? And how much of this was their choices? So we know how to treat them, and we know what to emphasize when we're dealing with these different issues. And it might be different for different clients. So what have I said so far? I said there's this sort of this confusing situation that we have, and we have a classical picture of this that you all have heard many times before. We have all these different people looking at this elephant from different directions. Remember the story about the blind people all looking at the elephant? One says it's a tree. He was on, on one of the legs, and it's a broom because they were on the tail, and, it's a water hose. Well, that's the same thing we have here, but we need to get some common way of talking about the elephant. And we need to understand how different people are looking at this from their different slants, and to sort this out so we can be effective counselors of what we're dealing with, so we can use the same terminology, because the truth is, everybody in all these different areas is dealing with what? A human being. And they're just looking at it from different directions, and they're using different methods to figure this out. But we're trying to integrate that for you in this class, so at least you get a rudimentary understanding of mental disorders and how to talk about them, and then maybe what is important to treat and how to treat them and how to help them. Let's pray. Lord God, we ask that you would give us wisdom, because we're taking on a lot here, and we realize there's so much. And Lord, that we just look into a glass darkly, that we don't understand so much. So we ask that you would help us, you would open our eyes, open our hearts, help us to understand, that we might be effective counselors in helping these people to know when to refer, to know when to help them, to know get them what kind of help that they need. And we'll give you all the glory and the honor in Jesus' name.